All right, so today we're going to be talking about orthostatic intolerance and mostly just the assessment of orthostatic intolerance in our post-viral patients, our long COVID patients, and those who may have ME/CFS. So just a quick introduction for those of you who haven't seen me before on the previous lectures. I'm from the Bateman Horne Center. We're a 501(c) nonprofit organization that spends time working on clinical care, research, and dissemination of educational resources for post-viral syndromes, for ME/CFS, for fibromyalgia, and for all the related comorbid conditions, including small fiber neuropathy, mast cell activation syndrome, postural orthostatic tachycardia syndrome, which we'll touch on today, hypermobile EDS, and of course, long COVID now. So just a quick reminder, in this series, we've been going through the clinical criteria for ME/CFS, which appear to apply to most of our patients with long COVID. So we're operating under the lessons we've learned from ME/CFS and the data we've already gathered in ME/CFS when making recommendations or assessments in our long COVID patients. So very, very briefly, it's a chronic debilitating multi-system illness. It's characterized by central and peripheral nervous system involvement, by dysfunction of the immune system, some parts being overactive, some being underactive, and by impaired cellular metabolism with a quick switch from aerobic to anaerobic metabolism. And it's thought to be post-viral and post-infectious in most, but not all cases. Things like traumatic brain injury can also trigger ME/CFS. And we really seem to believe that, with TBIs, for example, it's the immune response to TBI, much like an immune response to a virus or other infection, that may ultimately lead to this long-term syndrome, although we still have much to learn there. So just briefly, again, these are the diagnostic criteria for ME/CFS. They exist because we have no single sensitive marker for the diagnosis of ME/CFS or post-viral syndromes. So we use these clinical criteria that were developed in 2015 by the Institute of Medicine. They are core clinical criteria that help us define a population that likely have the same illness. But people with post-viral illnesses can have many, many, many other symptoms and comorbid conditions as well. And we just had a lecture on post-exertional malaise, which is really considered the pathognomonic feature or a defining feature for these illnesses that's not really found in any other set of illnesses other than post-viral illnesses. So please take a look at that if you haven't had a chance to look yet. But very briefly, we've got a substantial reduction in function, post-exertional malaise, unrefreshing sleep, cognitive impairment, which is waxing and waning, and then of course, orthostatic intolerance. And that's been a really large area of focus for us in post-viral illnesses, because in many ways it's quite measurable, and there's a lot that we can actionably do about it in the long term. But of course, we'll go into sort of treatments after assessments in our follow-up lecture in 2 weeks. So I also wanted to point out here, we've been seeing ME/CFS at the Bateman Horne Center for a long time, but we have also been seeing a lot of long COVID patients, given that they were meeting diagnostic criteria for ME/CFS as relates to those IOM criteria that we just showed there. And it's important to point out here that in both our long COVID and our ME/CFS populations that we've been seeing, they have very similar rates, 64% and 58% of reported orthostatic intolerance. And that's just on surveys before we even have a chance to assess them with some of the tools I'm about to show you. So this really does apply to many people and a higher percentage than 58 and 64% when we actually dig into it. Many people with long COVID and can be a really great way to move forward in helping them feel better. So what is orthostatic intolerance then? Well, quite simply, it's the development of symptoms in an upright posture or position that are relieved or partially relieved by reclining or by laying down. And orthostatic intolerance is important to think about in the context of gravity, right? So when we go from laying down to sitting or standing, there is more gravity exerting a force on the blood flow in our body, and specifically in our more upright positions like our brain and our head, neck, and shoulders. So healthy people are able to adapt to this change in position and the increased force of gravity on the circulatory system, and they can maintain blood flow to the brain through activation of their autonomic nervous system. That's our first line of defense or adaptation here. And this is a system that's detecting our change in position and sends all kinds of signals that help our blood vessels constrict and maintain the amount of blood flow we need to the upright areas of our body, including the brain, when we're upright. But when there is a dysautonomia or misbehavior of the autonomic nervous system, or just not getting the right signals to activate when it should, these initial adaptive features are inadequate enough to maintain blood flow to the brain so that people can function optimally. And it's important to remember that orthostatic intolerance is not just a feature of low blood pressure. It can be present with people with low blood pressure, normal blood pressure, or high blood pressure when they're in a seated position at rest. So it's really related to the development of symptoms rather than a blood pressure measurement per se. So when people are in this upright position and are feeling the effects of gravity or not having that normal autonomic response, it can worsen a multitude of symptoms, including things like lightheadedness and dizziness, heart palpitations, can affect brain fog, contributes to a significant muscle pain or aching, cognitive attention and focus can wane, gastrointestinal symptoms can change dramatically, headaches can be present, and shortness of breath can exist. So we kind of think of these in two major categories. There's those that are sort of related to cerebral underperfusion. That's our lightheadedness, fainting, impaired cognition, disorientation, headaches, visual changes, and even neck and shoulder pain and exhaustion. But we also have peripheral cardiovascular perturbations, which are really appear to be secondary to a sympathetic nervous system activation that occurs in response to that lack of blood flow to the brain, right? That's our secondary adaptive feature. And with this, we get palpitations, nausea, abdominal and chest discomfort, facial pallor, cold hands and feet, anxiousness, or even panic attacks, shortness of breath, sweating, and tremor, things you all associate with sympathetic overdrive or sympathetic activation, fight or flight activation. And the majority of these symptoms really are thought to be directly or indirectly related to maladaptive blood flow responses in upright positioning due to inadequate functioning of this autonomic nervous system. So orthostatic can be caused by or worsened by many factors. And whenever we see someone that we think has orthostatic intolerance, it's really important to think through these categories before we talk about some of the things we're thinking about for our ME/CFS and long COVID populations. So heart disease, including heart arrhythmias, heart valve failure, MIs, and cardiomyopathies can obviously worsen orthostatic intolerance. Lung disease, including PE or primary pulmonary hypertension, all kinds of medications can contribute to orthostatic intolerance, TCAs and diuretics being very common, as are medications for prostate disease in men, certain types of oral contraceptives, etc. Lesions to the central nervous system, including the brainstem, midbrain lesions, things like multiple sclerosis or Parkinson's, and even craniocervical instability from either a hypermobile syndrome or from trauma or a motor vehicle accident, something along those lines, can contribute to or worsen orthostatic intolerance. With Parkinson's in particular, there was a med called droxidopa or Nerthera that was developed to help with orthostatic intolerance in that population because it crosses the blood-brain barrier easily. Peripheral nervous system lesions can also contribute, including those in diabetic neuropathy, spinal cord injuries, small fiber neuropathies, and other autonomic neuropathies. And then, of course, environmental or behavioral impacts on orthostatic intolerance are not to be forgotten either. So things like heat exhaustion, dehydration, prolonged sitting or laying down with deconditioning. So if someone's been in the ICU for a long time, lack of exercise, or trigger in the setting of having not exercised much, then trying to exercise either during or immediately after that exercise, orthostatic intolerance can be triggered. There are several types of OI syndromes that are defined, and it's important to kind of know the terminology, but in many cases, orthostatic intolerance is often treated rather similarly at the end of the day. But because again, we're really dealing with a dysautonomia or a maladaptation of the autonomic nervous system. And what we're talking about here in these syndromes is just some definitions of things that we can actually measure that would alert us to the fact that there could be a dysautonomia going on. So in orthostatic hypotension, we see a blood pressure reduction of at least 20 millimeters of mercury systolic and 10 millimeters or 10 millimeters diastolic within the first 3 minutes of an upright posture from having been laying down or sitting. Postural orthostatic tachycardia syndrome, or POTS, is more related to the heart rate response, right? So the reproduction of orthostatic symptoms needs to happen, so they need to be symptomatic, and marry that together with a 30 beat per minute increase in heart rate when moving from supine to upright in a 10-minute period, or just a standing heart rate of greater than 120. So just a caveat there, if your patient is lower than the age of 19, that heart rate needs to increase by 40 beats per minute or be over 120 beats per minute standing to meet the definition for postural orthostatic tachycardia syndrome. We also have neurally mediated hypotension or syncope, which is pretty synonymous with our vasovagal syncope or neurocardiogenic syncope, and it's sudden syncope that occurs during quiet upright posture. And then we have orthostatic hypertension, which is a sustained increase in systolic blood pressure of greater than 20 millimeters of mercury and or 10 millimeters of mercury increase in diastolic blood pressure within the first 3 minutes of upright posture. So all of these are associated with symptoms of orthostatic intolerance, but they are different types of responses or adaptive responses that we can measure through vital signs. And many of them are mitigated or not as obvious when we're measuring them when we do treat underlying orthostatic intolerance. I do want to touch on POTS for a second in particular, because it's interesting that we refer to this as a disease or syndrome. But again, and I'm harping on this over and over because I think it's so important, this is an easily measured adaptive response to upright positioning when the initial functions of the autonomic nervous system fail to maintain adequate blood flow to the brain or other organs. So specifically in this case, what we're seeing is that the heart rate is increasing as an adaptive measure to increase overall cardiac output being stroke volume times heart rate. One of those is very manipulatable in a rapid setting, whereas the stroke volume can't change easily in short periods of time, unless, of course, the heart rate gets so fast that you have no diastolic filling whatsoever. So the increased heart rate in POTS, while it can be associated with palpitations and discomfort and anxiety and actually make people feel worse, this heart rate increase isn't the pathological process itself, but instead it is an adaptive response to the underlying pathology in the autonomic nervous system. And so many times I've seen patients go to medical offices, be diagnosed with POTS, and be given a beta blocker or Corlinor or something that reduces the heart rate response. And yes, that may reduce some of the symptoms associated with tachycardia and discomfort there, but it's actually blunting an adaptive response to the underlying pathophysiology, not improving the underlying pathophysiology. Something else that we see in POTS in a lot of our orthostatic syndromes is a narrowing of the pulse pressure. The pulse pressure, of course, is the difference between the systolic and the diastolic pressures. And this appears to be a vascular adaptive response to help maintain blood flow to the brain and other areas of the organs during dysautonomia and orthostatic intolerance. So especially mediated by a rise in diastolic pressure, which is really a function of muscle contraction or constriction in the vasculature so that we can get enough perfusion to the places that it needs to get when upright and when there's a failure there, or at least a decrease in perfusion as a response to gravity. So a lot of times the concept of reduced cerebral blood flow as a core manifestation of orthostatic intolerance has been, I think, ignored or debated in the literature. But as you can see here, there's pretty extensive literature suggesting that indeed there is reduced cerebral blood flow as a core manifestation of these orthostatic symptoms. And I wanted to touch on one of those studies in particular. Here. This was a set of patients where we have healthy controls and we have ME/CFS patients. And among those ME/CFS patients or post-viral illness patients, we have those who have a normal heart rate and blood pressure response to upright tilt table testing, those who show a orthostatic hypotension response, and those who show a POTS response, right? So either the blood pressure drop or the heart rate increase as a response to upright positioning, and those who don't show any changes in their vital signs, all among those post-viral illness patients. And what they did is they took these patients, put them supine, and then lifted them up on a heads-up tilt, and they used a high technical quality vascular ultrasound to measure blood flow into the brain from the vertebral arteries and from the internal carotids. And so what we show here is that there is a significant reduced cerebral blood flow throughout the course of a 10-minute tilt. So in healthy controls, there is a slight reduction in blood flow to the brain. That's true of all people, and that's why we need that autonomic response. But in our ME/CFS patients, you can see that there's a much larger decrease in overall mils per minute of blood flow. And that is present across all three subgroups there. And it gets worse over time in tilt. The same is true as far as percentages of decrease in cerebral blood flow. So very little change in percentage of blood flow in the healthy controls, and quite a bit of change. This is a magnitudes more of change in those with ME/CFS, and that's true of all three subgroups, including the subgroup where they had no heart rate or blood pressure changes to tilt. There was still a giant reduction in cerebral blood flow there. What's also interesting about that study is comparing the reported symptoms during heads-up tilt. So on this side, we have our healthy controls at 1-minute tilt and 10-minute tilt. Some did experience some dizziness and some visual changes, but otherwise there was a relative lack of symptoms during this heads-up tilt. However, in our ME/CFS and post-viral population, all of these symptoms were remarkable, both at 1 minute and at 10 minutes tilt. And some are even worse at 10 minutes tilt, whereas clearly they got better over time after that initial tilt change in our healthy controls. So this includes everything we talked about, from headache, palpitations, back pain, tingling neck and shoulder pain, nausea, gastrointestinal symptoms, shortness of breath, fatigue, dizziness, muscle weakness. All of those cropped up in relation to heads-up tilt in our population with that increased reduction of cerebral blood flow in that upright position. So a way to summarize the results of this study was that at end tilt, cerebral blood flow reduction was approximately 7% in our healthy controls versus 26% in the ME/CFS group. And if you look at the subgroups more closely, 24% of the patients in that ME/CFS group that had no heart rate or blood pressure response, or a normal heart rate and blood pressure response to tilt, they still had a 24% decrease in cerebral blood flow. There was a 28% reduction in cerebral blood flow in those with orthostatic hypotension, and 29% decrease in cerebral blood flow in POTS patients. These were all clinically significant reductions in cerebral blood flow during heads-up tilt in those with ME/CFS compared to controls, or in post-viral illness compared to controls. And this degree of reduction in cerebral blood flow was actually strongly correlated with how patients reported their symptoms. So the more symptoms they had, the more symptomatic they were, the more likely they were to have greater decreases in cerebral blood flow. So this Doppler imaging technique of the internal carotid arteries and the vertebral arteries is thought to maybe be an assessment tool for the future to help us with orthostatic intolerance. It's not readily available right now, but there's a push to get that into some offices to start using that as a way to really assess orthostatic intolerance, especially for those people who don't have heart rate and blood pressure changes to tilt, because there's still something going on there. What are things that we can do, however, right now in our offices to assess patients that we think might have orthostatic intolerance? Well, one really simple tool is to ask patients about the hours of upright activity, or time they spend with their feet on the floor in either a standing or a sitting position. And it's important to ask this question very clearly, because time spent sitting on the couch with your legs elevated, or sitting in your bed where you're sitting upright but your legs are spread out horizontally, is very different than having your legs under your torso and having the effect of gravity be able to drain more blood to those dependent areas. So we're really interested in time with feet on the floor specifically when measuring hours of upright activity. So it's important to point out that normal healthy people have approximately 14 to 17 hours of upright activity per day. Those with chronic illnesses like rheumatoid arthritis, COPD, fibromyalgia, congestive heart failure, multiple sclerosis, they have a reduced level of hours of upright activity, but are still relatively normal in comparison. They have 10 to 12 hours of upright activity per day. Our ME/CFS patients and our long COVID patients that we've been seeing spend anywhere from 0 to 7 hours of upright activity per day before they've received any treatment for their illness, for the most part. There are exceptions to that rule, but they fall into that category for the most part. So huge identifiable differences in how many hours of upright activity they experience. Very simple question that you can ask in an office, as long as you make it clear the difference between feet on the floor and not on the floor, to get a sense that orthostatic intolerance is playing a huge role in their symptoms. Another tool we use is a orthostatic hypotension questionnaire. And it's got two components to this questionnaire. The first is a 6-item symptom assessment. How bad are the symptoms? And then the second item is a 4-item daily activity scale to see how the symptoms are affecting people's activity. So in our symptom assessment, we look for dizziness, lightheadedness, weakness, fatigue, difficulty concentrating, head and neck discomfort, and problems with vision. Whereas the activity scale looks at standing and walking for short and long periods of time. And these are all scored on a scale of 0 to 10, with 10 being the most severe and 0 being no symptoms. We looked at 25 ME/CFS patients, all female, and 25 age-matched and gender-matched and race-matched healthy controls, and had them fill out their average hours of upright activity and correlate that with their orthostatic hypotension or orthostatic questionnaires. And we found that these orthostatic questionnaire scores and hours of upright activity were found to correlate very well with each other, and also with the severity of illness. So this here from left to right shows our healthy controls, and then our ME/CFS group on the right there with mild, moderate, moderate to severe, and severe symptoms. And you can see as the hours of upright activity decrease, their overall symptom scores increase. Their average symptom scores get closer and closer to 10 or severe as we lose hours of upright activity. So huge correlation there. The same was also true in our ME/CFS group with the severity scores, or the functional scores here. So as the hours of upright activity decrease, you can see the severity of the scores for standing and walking for short and long periods of time get worse. So huge correlation between the severity of illness, the hours of upright activity, and both the report of symptoms and of reduced function. The other thing that we will often do in our clinic, and that we are trying to get more people to engage upon either in their own clinics when they have time, or to ask patients to do at home, is a 10-minute stand or lean test. We refer to it as the NASA lean test. It was originally developed at NASA to assess the impact of orthostatic intolerance on those returning from an anti-gravity environment. But many times in the literature, you'll just see this referred to as a standing test. And it's interesting because the heads up tilt is the gold standard, but this may be more sensitive actually for picking up on orthostatic intolerance changes than a heads up tilt, and is an extremely useful tool in our post-viral population. So how do you do that test? Well, you have someone lay down for 15 minutes in a dark room, take away their cell phone, oh no, and just let them rest for a little while. And then we come back into the room and have the patient stand up. We measure their blood pressure, their heart rate, and their pulse ox, or SpO2, using the pulse ox, while standing against the wall with their shoulder blades against the wall and their heels about 12 inches from the wall. And the idea of this test is that we are assessing the impact of gravity on the autonomic nervous system without allowing someone to shift around back and forth, to change weight from one leg to the other, which activates the skeletal muscle in their legs, which then works on the venous pump and helps improve venous return to the heart and overall circulation. So when you take that away is when you can really provoke symptoms. And we measure heart rate and blood pressure, as well as SpO2, every minute for 10 minutes. And we also assess patients' hands and feet to look for vascular changes, and listen to patient-reported symptoms. So an example of a NASA lean test, this is a kind of a blank template we will use, and we would fill out the systolic and diastolic blood pressures, the pulse, and have comments on symptoms every minute for 10 minutes after getting a baseline immediately after laying down for 15 minutes in a supine position. And so here's an example of one in a 32-year-old woman that presented to us with severe fatigue, migraines, fibromyalgia, and dizziness that was unresponsive to traditional therapies. She definitely did not respond to meclizine, which seems to be a first-line therapy for everyone who's dizzy. So in the supine position, she had a blood pressure of 116/60 and a heart rate of 85 beats per minute, nothing that would really catch anybody's attention, right? But as you provoke standing in this Nasaline test, you can see that her heart rate jumps up to 125 beats per minute by 6 minutes into the Nasaline test. That's a 41 beat per minute increase, which of course meets our previously aforementioned criteria for postural orthostatic tachycardia syndrome. Not only that, but she also had big changes in her blood pressure here. 116/60 is a pulse pressure of 56. And you can see that not only did the diastolic pressures increase to about 80, but her systolic pressure, increased to about 80, her systolic pressures decreased. So her pulse pressure narrowed down to 13 millimeters of mercury from being 56 originally. That's the narrowing of the pulse pressure that we referred to. That's another adaptive mechanism to this physiological stress of being upright. She reported that her arms felt like they were tingling. She had lightheadedness and dizziness with some spinning and nausea and an electrical buzzing sensation during the test. We also noted changes, and these aren't directly from this specific woman, but these are the type of vascular changes we note in people's hands and feet during a Nasaline test. And really interestingly, you get this sort of almost acrocyanosis, venous pooling sort of look to things. And you can press your thumb into it and see marks like this on the feet or the hands. And it may take 5 to 6 seconds for the color to come back to that dusky looking color that you see there. So this is really provoked on a Nasaline test as well, and it's highly suggestive of orthostatic intolerance. Why 10 minutes, right? Why not 3 minutes? Why not 2 minutes? Why not just like we were all traditionally taught, you know, do the heart rate and blood pressure laying down, sitting, and standing? That's what I learned in internal medicine. Well, because you miss diagnoses of POTS, at least, as you can miss up to 68% of diagnoses of POTS within 1 minute of a upright provoked testing here. And we've actually done studies both with male and female patients and those who are young and older to find out that you really need to go a full 10 minutes to not miss any diagnoses of POTS. Up to 7 minutes gets most cases, but this is going to be the most sensitive way to pick up on orthostatic changes, or at least heart rate increases as part of a response to an orthostatic challenge. One last thing that we do in our clinic, we use this Dana Brain Vital for 5 minutes. We have patients download an app that was developed by the military to really assess cognitive performance and function. And they'll do this both before and then after a Nasaline test. And there's 3 kind of small little games that they play on their cell phone. The first is called simple reaction time. A bullseye appears and you just have to tap it as quickly as you can. The second is procedural reaction time, where you have to choose either a 2-3 or a 4-5 when they light up. And then the last is called go, no, go. There's 2 little aliens, a green one and a white one, and they'll pop up in different windows. You have to tap on, I forget if it's green or white, which are the bad guys, but you have to tap on one color and not tap on the other color. And we see that there are slowed reaction times for those patients who have orthostatic intolerance post-Nasaline as compared to pre-Nasaline. And this is one of our most sensitive measures of impaired cognitive function as a result of orthostatic challenge. So right here is our ME/CFS population, our long COVID population, and some healthy controls. And simple reaction time was probably our most sensitive of those 3 tests, again, hitting the bullseye. And you see that pre to post test, there's a huge decrease in overall cognitive efficiency in both ME/CFS and long COVID. Long COVID is actually starting out at lower cognitive efficiency and then actually decreasing similarly to those with ME/CFS pre and post test. This may be a factor that's related to how long someone has had a post-viral illness and how many other adaptive mechanisms their body has been able to implement since they initially became ill, which is maybe why ME/CFS patients have a similar pattern, but overall slightly improved cognitive efficiency. And you see similar reactions here with the procedural reaction time and go, no, go in our long COVID population, but it's not as sensitive in our ME/CFS population. Healthy controls, however, actually show a learned response and get better after a Nasaline test. And that's across all 3 domains there. So these are some other resources for orthostatic intolerance and POTS. Dysautonomiainternational.org is a good resource. We have a lot of educational videos on our BHC or Bateman Horne Center YouTube website, as well as lots of other provider resources. And really, if you need more information on post-viral illnesses, long COVID, the paper we produced through a clinician coalition on ME/CFS in the Mayo Clinic Proceedings really gives a good overall summary of what we think is going on and things that we've found to be tried and true treatment methods to help your patients. We will talk in the next visit about how to, once we have assessed orthostatic intolerance, how we might go about treating someone who has these symptoms. But for today, we will cut it short there.
Dr. Yellman, thank you for your presentation. Do we have any quick questions before we get into our case review? Really rich conversation today, guys. Thank you all for joining, and our expert panel, and both Dr. Hoppers and Hoffman for your questions. Our next session will be on June 14th, and Dr. Yellman will be discussing OI interventions and management. So hope to see you all there. Until next time.